the system to cover your employees for emergency access, maybe you should be paying something for that privilege. That's the basic idea. Okay, greater equity and public supports for coverage. So this is how the Affordable Care Act is supposed to work, right? This chart includes what are called insurance exchanges. So the Act sets up these new insurance marketplaces in every state. States may have set them up, or the federal government set them up for states, depending upon what states decided to do. And these insurance marketplaces allow private insurers to offer insurance to people in a market that is very clear in terms of what people are offering. You can buy a platinum plan, or a gold plan, or a silver plan, or a bronze plan. Any of you gone on the insurance exchanges to look at this? Okay. Somebody in the back over there. So there are different levels of plans that have different levels of coverage and different premium rates. And the idea here is, instead of having me as an individual go out and buy insurance for myself, which is really expensive, because the insurance company doesn't know how risky I am, so they charge me a lot of money, if you can create a pool of people, you can bring down average costs. That's the basic idea of these insurance marketplaces, is let all the individuals come together and buy insurance as a group, protecting each of them a little bit. But there's also an idea that there would be competition. So different insurers offer different plans at different rates, right? And as you see on the chart here, some of that is subsidized. You can get subsidies up to 400% of the federal poverty level, which is $95,000 for a family of 4. So families of 4 who earn up to $95,000 are eligible for subsidies on the insurance marketplaces. Okay? And the idea here is, if you're mandating people to get coverage, you got to make it affordable somehow. You got to help out to make it more affordable. So that's the basic idea of the insurance marketplaces. So that's what the yellow is, and that's also what the purple is. Those are all insurance marketplaces. Okay? And then the red designates sort of average rates of Medicaid eligibility before the Affordable Care Act. And you can see that parents, right, there are lots of parents who don't have Medicaid coverage, and they're seniors. Medicaid covers seniors? And people with disabilities, that's what Medicare covers, right? 75% of Medicaid is spent on elderly and disabled people, not on poor people, technically. Okay? That's a little bit of a surprise, isn't it? And if you don't have children or you're an adult, you're not going to get Medicaid. So the Affordable Care Act says, well, it doesn't work. Because people who make below 133% of the poverty level simply can't afford health insurance. So we're just going to make it universally available through Medicaid to anybody who makes 133% of the poverty level or less. But states could decide whether they wanted to get on board or not. Okay? So this is how the Affordable Care Act was trying to connect more people to health insurance. Create these insurance marketplaces and expand Medicaid. Right? So this is a slide that just indicates the kinds of subsidy rates you can get at different levels of the poverty rate, different rates of the poverty level. Sort of not very easy to understand, but if you get access to this, there's a subsidy calculator you can use to calculate what kind of a subsidy you would get. Maybe a more useful thing to say is this. 8 million Americans got insurance through the insurance exchanges in 2014. Okay? 8 million Americans got insurance through the exchanges, and 85% of them received subsidies. And on average, their subsidies lowered the cost of their care by 75% in terms of the premiums they pay. So that's a significant benefit. And the average premium price was $82 a month for people buying insurance through the insurance exchanges. So, you know, coverage for the year at about, I should have done the math before, about $1,000 a year. Now that probably has a deductible on top of it, so it's not 100% coverage. I mean, we need to be realistic here. So, but nevertheless, it provides a kind of level of coverage for people. Okay. So what actually happened is states could opt out. And the states in yellow opted out of the Medicaid expansion. So the way the Medicaid expansion worked was the federal government, well, let me just say something about Medicaid quickly. Medicaid is a federal state program. So federal government provides some money for Medicaid, and then states provide some money for Medicaid. Okay? Under the Medicaid expansion, the federal government initially is providing 100% of the money for the expansion. And then it drops down to 90% of the money going forward. Okay? So states that said no were saying, even though the federal government is paying for the first 2 years fully, we're not interested in participating. And even though the federal government is going to cover 90% of those costs going forward, we're going to stay out because we don't want to expand Medicaid because we don't think it's an effective program. That's usually the reason it's given. So this is the reality today. In states like Indiana, for example, right? We didn't expand Medicaid in Indiana. So there are these black holes for people who don't have insurance coverage either through the insurance exchanges or through the Medicaid expansion. And those numbers run about 350 to 400,000 Hoosiers. Significant number of people falling in those black holes today. Okay? Some of whom are subject to the individual mandate. So that's a double mandate. Okay, so I've talked about 3 of the main ways that the Affordable Care Act is expanding. One is lowering coverage barriers. Lowering barriers to coverage. Another is broadening shared responsibility for paying into the system. And then the third way is what we're just talking about, making public supports for health coverage a little bit more equitable. So implications for health professionals. One of the things that people don't really know about the Affordable Care Act is the ways that reimbursements are changing. And this is actually maybe one of the biggest consequences of the Affordable Care Act. And this may be where it really connects for people who are thinking about going into the field of medicine today. The Affordable Care Act has no effect on graduate medical education funds. 0. They stay steady. So if you're asking about support for graduate medical training, it's staying the same. The Affordable Care Act doesn't have any implications for the graduate medical education funds that go to residency programs or that go to hospitals that do a lot of care for indigent patients. Those are going to stay at the same levels. In fact, the Affordable Care Act increased funding, the Affordable Care Act increased funding for what's called the National Health Service Corps. So if you end up doing medical training or even training, nursing training, medical training, there are various ways, and you want to work in an underserved area, this program will pay off some of your debts, right? And so maybe there's going to be expanded funding which would help pay off debts for people who want to go that route through this kind of a program. And it's a great program to consider working through. There are some ways that federal reimbursements change through Medicare. So one of them is there are plans called Medicare Advantage plans. These are Medicare plans that are run by private insurance companies, and they generally cost more than the public Medicare program. One of the things that's changing is the extra money being paid to those Medicare Advantage plans is being removed. And it was supposed to be removed starting in 2015, but it was delayed a year. This has been happening a lot, right? And one of the real frustrations that people have with the implementation of this law is all of the delays that keep happening. There's also this program, the Hospital Readmissions Reductions Program, which says if you've treated somebody for a condition and the person returns within 30 days with the same condition, we're not going to pay you and we're going to penalize you for doing so. So this program collected $280 million in 2013 from hospitals that had readmission issues with patients. So that's a change that comes from the Affordable Care Act. There's also this Independent Payment Advisory Board, which is supposed to recommend cost savings, but more importantly, if Medicare inflation is going up too fast, they recommend ways to control costs. And Congress has to say yes or no. They can't fiddle with it, right? Since Medicare is not going up very much right now, this is pretty irrelevant for the moment, but we'll see if it comes into existence later. Some other reimbursement shifts. There's something in healthcare called diagnosis-related groups. So Medicare bills pays based on diagnosis. And private insurers basically follow what Medicare does. So this really matters a lot. And the way these diagnosis-related groups work today is hospitals get pretty high reimbursements, specialists get pretty high reimbursements, and primary care doctors get pretty low reimbursements. And this is an issue in terms of how we have payment structures set up in our system. That doesn't change as a result of the Affordable Care Act. That actually stays in place. But one of the things that is ended by the Affordable Care Act is there was a period in which physicians were creating their own hospitals, their own specialty hospitals. Medicare will no longer pay new physician-owned specialty hospitals for services, which basically means none will be built, because hospitals rely about 50% of their funding on Medicare and Medicaid. So basically it said we're not going to support that kind of physician entrepreneurship. And then finally, the ACA provided a bonus payment for primary care through Medicare and also through Medicaid, trying to boost some of those primary care rates up. This is a really interesting part of the Affordable Care Act. So there's something called accountable care organizations. And the idea of an accountable care organization is I'm a hospital, right? But I have patients who go to a clinic, and maybe go to a specialist over here, and the patient goes to all of these people individually, right? What if we work together? What if we work together? Maybe we could deliver a more integrated form of care at a lower cost. And the government says, okay, if you can reduce costs, we'll give you half of the money back. Or some portion of the money back. Well, this has happened in McAllen, Texas, which was famous for having the highest cost and the worst health outcomes in the United States. And some people created an accountable care organization, and you see they saved $20 million over that period, increased the number of patients with diabetes being controlled and vaccinations being received. So this suggests that maybe these kinds of reforms can deliver more integrated care, which is a very important part of healthcare. Another big question facing us in terms of the organization of healthcare is we do a lot of care in the hospital. Care in the hospital costs a lot of money. Maybe we should do more care in the community, earlier. And the Affordable Care Act begins to shift funding in that direction. It lowers disproportionate share hospital payments, slashes them by 75% starting now. That's a lot of money. That's $15 billion gone for hospitals. And it begins to invest more in what are called federally qualified health centers by building more. So one of the ideas is, well, let's build clinics where people that can be in people's neighborhoods, where people can get care earlier on a more continuous basis. But one of the questions is, what's going to happen to hospitals? And this is a big question the hospital administrators are facing right now. Last slide, and then I'm going to wrap it up and see what questions people have. Another aspect of the Affordable Care Act is it creates this patient-centered outcomes research institute, which is designed to collect what's called comparative effectiveness research. So comparative effectiveness research says, okay, David has diabetes, and he could get this treatment, or he could get this treatment, or he could get this treatment, or he could get this treatment. Which one's more effective? What are their benefits? What are their liabilities? That's what comparative effectiveness research is. And this institute is going to begin to fund studies and collect information on this. They are not allowed to pay attention to the cost of care. But physicians and patients can pay attention to the cost of care when they're thinking about, well, this is basically just as effective or almost as effective, but this costs 10 times as much, and I'm paying for it, I'll go with this treatment. Well, this raises really tricky ethical questions, right? But there's a recent study that found that with laparoscopic, so this is for appendectomy. So parents were given the option of having laparoscopic surgery for their kid or having open surgery for their kid, both of which were equally effective, but one of which was $2,000 more. And patients were 1.8 times as likely to choose the cheaper option. The parents were likelier to choose the cheaper option, even for their kid. This may be somewhat surprising and suggests that maybe there need to be more conversations about cost happening in the doctor's office. But this raises really tricky ethical questions, right? But it does take us back to the question about how are we going to expand care, expand coverage, while also trying to keep costs in check. And to me, this is the really big challenge that we're facing today. And the Affordable Care Act, to my mind, does a pretty good job of building on what we've already built. It's complicated. It's, you know, there are a lot of things people don't like about it. But we have a really complicated healthcare system. And it's probably going to take a complicated response, I think, to be able to make some head. So anyways, I'll stop there. Thank you for your attention. I know that was a lot of information. Hopefully